trenches. Today's topic is cardiac tamponade. This is at the request of my medical student, Carmine. Okay, obviously, this is something we don't see in the office too often, like never, but let's talk about it anyway. So, when would I see cardiac tamponade? When would I think about it? Well, the big thing is hypotension. And if you go through the causes of hypotension, pumps, pipes, perfusion, and pharma. Okay, this is anything cardiac. This is vasodilatation like sepsis. This is hemorrhagic. And these are meds, and you could have a combination of anything. If a patient is hypotensive and you examine them and they exhibit something called Beck's triad, where they're hypertensive, yet they have JVD, a low blood pressure, and muffled heart sounds, you'd have to think of tamponade. Obviously, to repeat, we really don't see this in the office, but theoretically it's possible. Something else you would hear when you're attaining blood pressure, you will hear pulsus paradoxicus. The other thing that does that is status asthmaticus and rarely severe COPD. What happens with pulsus paradoxicus is that when you take a deep breath in, you're going to cause a shift of the intraventricular septum, which is enclosed by fluid, and there'll be less fluid going out. And your blood pressure will be lower by at least 10 millimeters systolic upon inspiration. If you feel a patient has cardiac tamponade, you're going to get an EKG, and normally you're going to see very low voltage on the leads. Okay, and you may see something called pulsus alternans. What could cause tamponade? There's a huge differential. When you think of maybe an evolving pericarditis, viral syndrome going to this, or an acute complication of an MI. Now, there are a slew of other things that could do this, but in the office, you're not going to have time to make a differential. Now, if you suspect pulsus paradoxicus, you got to get the patient to the emergency department, and they need to be dealt with there. Okay, there they could get a bedside echo. You could do POCUS on that. You'll see fluid surrounding the ventricle. The classic diagnostic test we learned is doing a right heart cath, and you see equalization of all the pressures: right atrium, right ventricle, pulmonary artery, left atrium, left ventricle. They're all equal. And if you suspect this, initially you can do a pericardiocentesis, maybe infuse IV fluids, and then do a window. But let's take this back a step. This was a question brought to me, what can I say about this? So obviously, somehow a patient could stumble in the office with this. And what do you really do? If someone's hypotensive, and we see hypotensive patients in the office, often they're septic, and they wind up in the office first. But if they're hypotensive, you have to at least think of these. Okay, if they're hypotensive and they hear a pulsus paradoxicus, and you have to at least think about it, you're going to think more of this. And if they have JVD and muffled heart sounds, you have to say this is possibly pulsus paradoxicus. That point in time, you really ought to be calling the rapid response team. In the interim, you could get an EKG, and if they're muffled heart, if there's very low voltage, that's giving you a clue to this. Now, if a patient recently had an MI, or they're complaining of chest pain, an aortic dissection could also, that's how a lot of these people die. They develop acute aortic insufficiency and tamponade secondary to that. So they may have warning symptoms. You need to really get them out of the office and get them to the emergency room. in our office, and I doubt any office, you're going to be able to do a pericardiocentesis. That's the emergency procedure, and you need to image the heart. Initially, with a POCUS, then they'll need you know, um, an echocardiogram with more sophistication. And that's all I have to say about cardiac tamponade. Interesting topic. Not going to see it in the office.